I want to thank the Valley Fever Center for excellence and the Arizona Department of Health Services for sponsoring this meeting, which I think has become quite successful. What are the goals of this symposium? So at the end of this time, you should have a good overview of what the epidemiology of coccidioidomycosis is in Arizona. You should be able to recognize primary pulmonary coccidioidomycosis, understand the currently available diagnostic tests, and have some concept of how to manage, and I should say both primary pulmonary and disseminated coccidioidomycosis. Our speakers today are going to be Rebecca Sunenshine, who is with the Maricopa County Department of Health and the Centers for Disease Control, Janice Blair from the Mayo Clinic Scottsdale, myself, and Mike Sobel from Banner Health in Phoenix.
Thank you everyone. I'm really glad that you all came out here today in a dust storm to learn about valley fever. The irony just cannot escape me. It's always a pleasure to do this presentation with this group of incredibly talented physicians. So I'm going to talk to you today about the epidemiology of coccidioidomycosis in Arizona, and actually in the U.S. The objectives of this talk are to understand the epidemiology of coccidioidomycosis in the U.S. and Arizona, to appreciate the impact of cocci on Arizona's citizens, healthcare system, and economy, and to know what public health is doing about cocci in Arizona. So just starting with a basic overview of coccidioidomycosis epidemiology, it's of course caused by a fungus found in thermic soil. Basically that's sort of a sandy, salty soil. There are two species of coccidioidomycosis, C. immitis, that is predominantly found in California, and C. posidacei, that is the predominant type found in Arizona. They are clinically identical, so the actual species doesn't really matter. It's endemic in the southwestern United States, Mexico, parts of Central and South America. As you can see on this map that was done based on skin test results in the 1950s. Unfortunately, this is probably the best map that we have for cocci epidemiology, and you can see that Pima, Maricopa, and Pinal counties are the hot spot for cocci in addition to parts of California. 60% of all reported U.S. disease is actually reported from Arizona. So that's one of the reasons why we hold this conference every year, is because if you practice in Arizona, you have to think like an Arizonan clinician, and cocci is just going to have to be much higher on your differential than it is in other states, and we'll hopefully present enough data today to convince you that that's true. So coccidioidomycosis, which I'll call cocci from now on, is an important public health issue, and there is no licensed vaccine available, and it's a reportable disease in both Arizona and the United States, both by laboratories and by physicians. It's transmitted through inhalation of airborne arthrospores from the soil. Those arthrospores are blown by wind, also with soil disturbance, construction, outdoor activities, gardening, golf, any of those things that disturb soil can cause infection. The incubation period, or the time from when you are exposed to when you develop symptoms, is anywhere from 1 to 4 weeks. There is no person-to-person spread, no animal-to-person spread either. That comes up a lot. And cocci is usually found in soil about 2 to 8 inches from the surface. And that's really important because a lot of folks worry about mining and things like that in soil that has been disturbed for a long time. And once you get below about 8 inches from the surface, you really don't find those cocci spores. So risk factors for primary cocci, there's really only 2. You have to be exposed to an endemic area. You can live here or travel. And unfortunately, for the males out there, they are more likely to get cocci for whatever reason. Risk factors for disseminated cocci or more severe forms of disease, infants and elderly, in this case, individuals older than 65 years. Male sex again. Filipino, African American, Native American, and Asian race are definitely risk factors. I generally believe that Hispanic ethnicity is actually not a risk factor, but there are some studies that show that it might be. But I think the general belief among experts is that Hispanic ethnicity is not a risk for disseminated cocci. Immune-naive individuals and pregnancy is one of the biggest risk factors, especially in the third trimester and just postpartum. So that is your immune system is completely altered, and for whatever reason, cocci can wreak havoc in women who are in that last trimester and just gave birth. And of course, immunosuppression, including HIV. So the spectrum of disease, this is a slide that Dr. Galgiani put together, and we all use it. And it just helps us understand how much cocci is out there and how much of it you're actually going to see as a clinical practitioner. So out of 100 infections, 60 are going to have no symptoms at all. About 40% will have any symptoms. Of the 60 that don't develop symptoms, they go on to develop lifelong immunity. So those people will never know that they had cocci, will likely never be tested, and they'll never have any issues with it. Of the 40 who are symptomatic, about 37 of them recover. And a lot of them will have mild enough disease that they'll think that they had a viral illness, or maybe they think they were just really exhausted for a long time. And a lot of them will never actually know that they have the disease either. So those 37 recover, and a few of those may actually recur if they are treated with immunosuppressive agents or have an immunosuppressive disease later in life. About 2 to 4 out of those original 100 will go on to disseminate. And those are the ones, of course, that need to be identified right away and have to have treatment, or the disease will be fatal. And you'll hear, actually, from these 4 talks, you may hear 4 different numbers on the percent who go on to dissemination. You can find a ton of estimates in papers, and you'll see numbers all the way up to 5%, quite honestly. My belief is that it's less than 1%, and most of the estimates that are out there are based on reported disease, and so much disease goes unreported that it's probably less than 1% in reality that disseminate. So these are the best we can do with estimating prevalence, because the coccidioides skin test is no longer available in the United States. Actually, Mexico still has it, and they are working on approving that. I'm hoping either one of the following speakers can comment on where they are with the cocci skin test. But we don't have it available now, so that was the best way we had to estimate prevalence. So some experts came up with these figures, that there are approximately 150,000 cases annually in the United States. And since we know 60% of reports come from Arizona, that means about 90,000 would come from Arizona. And since only 40% are symptomatic, it's estimated that about 36,000 would be in Arizona per year. And if you look at Maricopa County, we actually, we did a serology test. There's someone here from CDC Mycotics, and they were kind enough to come out and help us do a sero survey in the Northwest Valley. And what we did was we looked at remnant sera from individuals that were over 65. So this is not a random sample in any way. This is individuals that were over 65, and we looked at a specific area of the Northwest Valley and compared it to the rest of Maricopa County. But what we found was that in this specific area, there were 9 of 797 sera that were seropositive by immunodiffusion. And in the remainder of Maricopa County, 0.75%, or 6 of 797, were positive. So what that tells us is that in the whole of Maricopa County, the seroprevalence is probably about 1% by immunodiffusion at any one time. And what we know is that that's probably an underestimate, because there are folks out there that are infected with cocci, and you'll hear a lot more about this later, that won't be positive by immunodiffusion because it takes some time to develop an immune response to that. So that 1%, or 0.94%, is probably a slight underestimate. So I talked already about the seroprevalence survey, and the objective was to compare a very high reported rate in that Northwest Phoenix area compared to the rest. I already really talked about the methods. And basically, when you break down that 0.94%, the prevalence estimate is anywhere from 40,000 to 60,000 cases at any one time in Maricopa County. So that's a lot of disease. That's at one time, and again, that's probably an underestimate because of the fact that immunodiffusion doesn't pick up all the active cases. So for cocci surveillance that we do in public health, you always have to take into account a couple of caveats. First, for this disease, only 40% are symptomatic. And we've estimated that since a lot of them think that they have a viral illness or maybe they don't have access to care, that probably less than a third of those are ever clinically evaluated. Probably anywhere from 8 to 10% of the total infections are ever serologically confirmed because docs don't necessarily think of cocci and they don't necessarily order testing. And even if they do order testing, if it's too early in the disease, it's going to come up negative. So only serologically confirmed cases are generally reported to public health. So all the numbers that you're going to see me present are going to be underestimates of the true disease burden. But one of our goals today is to get clinicians thinking about cocci early and often and getting them to diagnose it more to lessen that underestimate. So this is a graph from Dr. Galgiani that he put together comparing Arizona data to California data. And I think it's helpful to put that in perspective. And you can see the kind of orangey color is California, and that lighter color is Arizona. And what you can see is that before 1997, which was an important year for us in Arizona, before it was laboratory reported in Arizona, most of the cocci came from California. But as you can see that since 2000, the vast majority of cocci does come from Arizona. So this is the rates of reported valley fever in Arizona from 1994 to 2010. The lab reportability began in 1997, and that's when every single positive laboratory test for cocci was reported to Arizona Department of Health Services and was counted as a case. And that's why you see that fairly rapid rise around 1997. But what you see is a continued rise all the way up through the first decade of 2000. And what I want to point out is that in 2008, the rate goes from about 73 and jumps up to 155 per 100,000 people in 2009. That huge jump actually represents an artifact of reporting. One of the major labs in Arizona had not been reporting EIA serology unless it was confirmed by immunodiffusion to public health. And what happened in 2008 was all of the positive serology by EIA, regardless of confirmation by immunodiffusion, was reported to public health, and all of a sudden the rates doubled. So we don't actually believe that there was a rise in disease. We believe that that level of disease was always out there. We just weren't detecting it because of the reporting method, and that these rates that you're seeing, 155 in 2009 and 186 in 2010, that those represent a more accurate assessment of disease burden in Arizona. This is a map just to visualize. The darker the color, the higher the rate of cocci. And as you can see, the vast majority of cocci in Arizona is in Maricopa, Pima, and Pinal counties. Ever since the haboob in July of 2011, we've been doing some heightened surveillance to see what type of effects the recent dust storms have had on the cocci prevalence. Dr. Galgiani has been working really hard with Clarissa Sang at ADHS to follow the data on literally a weekly basis, and he was kind enough to let me present these slides to you. So this first one shows the valley fever cases per week in 2011. And as you can see, the date is on the x-axis, and it's just the number of cases on the y-axis. So it's not a rate. I don't want to make anyone think that it's a rate. So it's just a number, but what's interesting is the trend. And what you can see, Maricopa is represented by the yellow line, which of course has the vast majority of cases. Pima is the pink line, that's the second highest rates, and Pinal is down there below Pima. But what you can see, surprisingly, is right after that July 5th haboob, there was a considerable decrease in reported valley fever, and we do think that may have been an artifact. But you can see that a few weeks later, it did seem to go up a little bit. There's a little bit of a spike. Looking at cumulative valley fever in Maricopa County, what this is the yellow line looks at Maricopa County numbers of cases and the trend line in 2011 compared to the white line, which represents the number of cases by over time in 2010. And what you can see is if you just follow the slope of the line is that it's a much steeper slope in 2011 following that July 5th haboob compared to 2010. So it does look like we're seeing a greater increase in valley fever after the haboob. So this is that same graph for other counties, and the pink is represented by Pima County. The solid line is 2011, and the dotted line is 2010. And you can see that the numbers and the slope is a little bit steeper all the way around for 2011 compared to 2010 in each of those three counties and the rest of Arizona. So I want to tell you a little bit about what we know about our reported valley fever cases in Arizona. Again, these are the ones that seek care and that get diagnosed and are reported to public health. So you're probably seeing a sample of cases that are more severe because they're more likely to be detected. In 2007, we were able to look at the 5,000 cases that we had reported to us and sample 1 out of 10 of them and actually do a more in-depth interview to get information about those cases. At the time, 54% were male and 46% were female. Looking at race, about 6% were Native American, 3% were Asian, and 8% were African American. The average age was about 51 years, ranging from 38 days to 99 years. And interestingly, the rates among individuals over 65 years were more than twice the rates in the general population. So that's really important. We know that individuals over 65 are at higher risk for dissemination, but there also may be some bias in there that they may be more likely to seek health care, or they may be more likely to experience the symptoms and be concerned that they are related to another chronic illness. So this is just a graph from 2000 to 2007 showing you the valley fever rates in individuals greater than age 65. And you can see that over time, since 2000, the rates among individuals over 65 have definitely been increasing. So when we did our enhanced surveillance investigation, our goal was to evaluate Arizona's coccidioidomycosis surveillance system to identify issues contributing to delayed diagnosis and underreporting, and to measure the impact of coccidioidomycosis on Arizonans. We really wanted to be able to show the legislature, clinicians, people who may have some money to develop a vaccine, that this was a significant disease, that it was Arizona's issue, and that we really needed to put some effort into it. So again, the methods were that we telephoned every 10th case. Interviews were conducted using a standardized questionnaire, and after 3 attempts, that subsequent case was contacted. So to tell you a little bit about the Coxie case definition, and I don't want to go into this too much, basically CDC and the Council for State and Territorial Epidemiologists get together to decide what we're going to call a case of Coxie in public health. That definition, with some help from Arizona data, was actually updated in 2007. And before that time, Coxie was treated like a typical infectious disease where it required a rise in serology, rising titers over time. And that's just not necessary for Coxie. If you have a single serology result in Coxie that is positive, whether it's IgG or IgM, it generally indicates that you have active disease. So we were able to change the definition that an isolated IgG or IgM did count as a case, not just in Arizona, but nationally. So since 1997, Arizona has done something unique. Because we have so many more cases than the rest of the country, we have actually not required the clinical symptoms to be met. As long as they had a positive serology, they were counted as a case of cocci. So we just used the lab criteria. And part of the reason we did this enhanced surveillance was because we wanted to make sure that that was a reasonable approach, that there was enough cocci here that if you had a positive lab test, that it meant that you more likely had cocci. Even if we weren't looking at the clinical symptoms, we wanted to know in this sample at least what percentage actually had a clinical syndrome consistent with cocci. So we interviewed almost 500 cases, and what we found was that 95% of Arizona cases that we interviewed actually met that clinical case definition. And only 3% of cases reported no symptoms at all that were consistent with cocci. So what we found is that even if you don't look for clinical symptoms, don't take the time to get the medical records, 95% of them among this pretty large sample actually did meet the clinical case definition, and that validated our current surveillance system. We learned that the common symptoms of valley fever, which is consistent with the literature, the most common symptom, 84% of cases reported fatigue. And you'll hear that all the time. People will be like, oh, I'm not sick, but I just feel like a truck hit me. I couldn't get out of bed. Those kind of things. Unfortunately, that's not enough to meet the clinical case definition, but that is the most common symptom. 67%, about 2/3, had cough. 60% had shortness of breath. And interestingly, 54% of reported valley fever cases actually had fever. So I think that's difficult for clinicians who think of this disease as valley fever. They think, well, if you don't have a fever, you don't have the disease. Well, about half of folks who have this disease don't have a fever. And then the other thing I want to highlight down toward the end is I want to highlight rash. About 34% of folks presented with rash. That's pretty high. And hopefully we'll present enough data today that, based on a study that Dr. Blair did, that'll convince you that if somebody presents with community-acquired pneumonia and a rash, that should always make you think of cocci when you're practicing in the Southwest. So the impact on the healthcare system, almost half of the people we interviewed went to the ER for their valley fever. Over 40% were hospitalized overnight for their disease, and about a quarter saw their doctor at least 10 times during the course of their illness. I think a lot of the public, and maybe even some clinicians, think that valley fever is just like having a cold or the flu. But a lot of folks have really severe and prolonged disease, and I think these data really help show folks that. What we learned was that 23% of people with valley fever first sought care for their symptoms in an emergency department. And that told us that we needed to get the message out to ER docs to be thinking about valley fever so that they could order the test. And any of you that have worked in an ER or know what an ER's life is like, it's not that easy to order a test that you're not going to be able to follow up on that night. So that's a little bit of a struggle. But what we're hoping is that hospitals will support ER docs in ordering the test and that there'll be a good mechanism to follow up on those tests and let patients know their diagnosis after it comes back. So from the hospital discharge database, we learned that 70% of inpatient visits for cocci actually started in the emergency department. That was another clue that we really needed to reach ED physicians and talk to them about diagnosing cocci. So regarding the impact, looking at duration of illness, cases were sick for an average of 6 months or a median of 109 days. That is a really prolonged illness. That wastes away mononucleosis, which I used to think of as a primary care clinician as one of the most difficult diseases for people to get through regarding fatigue. Cocci is way worse. 75% of cases reported missing work due to cocci for an average of 1 month and a median of 2 weeks. 75% were unable to do their usual daily activities, and that was for an average of more than 3 months and a median of a month and a half. So that's significantly life-changing when you look at the effect that this disease had on people. So looking at the data from 2007 from the hospital discharge database, which actually collects the discharge diagnosis by administrative code for every single inpatient discharge in Arizona, we found that there were 1,735 COXI-related hospital visits in 2007. This accounted for $86 million in hospital charges with an average of $50,000 per hospital visit. So again, this is pretty costly for the economy in Arizona and for the healthcare system. We also learned that cases waited an average of 44 days before seeking care for their valley fever. The average time between seeking health care and getting diagnosed was 5 months. But in a separate study that we did amongst, actually in an additional question that we asked them, whether they knew about valley fever prior to their diagnosis, we found that those who knew about the disease prior to seeking health care were much more likely to be diagnosed and treated earlier than those who had never heard of the disease. And that was 79 days compared to 282 days with a significant p-value. So that let us know that we really needed to educate the public about valley fever too, because they were actually huge proponents in getting their docs to diagnose them. We also learned that a mean of 3 provider visits occurred before COXI diagnostic testing was ordered. And that's actually a median of just over 2 visits. So there's another survey out there that Public Health does routinely every year, the Behavioral Risk Factor Surveillance System. And that's where we were able to ask the general public in Arizona a few questions about valley fever. And it is designed to represent the entire population of Arizona. What we learned is that 1 out of 5 Arizonans have never heard of valley fever. 60% believe valley fever is a significant health problem. 40% don't think it's a big deal. And more than a third of the general public don't actually know how valley fever is transmitted. So that told us we had some work to do with education. Length of time lived in Arizona. The average for the entire population was 26 years. 25% had lived in Arizona for less than 10 years. When we looked at our enhanced surveillance data, so all those individuals who had been diagnosed with COXI, the average that they had lived in Arizona was 16 years, and 40% lived in Arizona for less than 10 years. And while that is a significant difference, I think it actually dispels the myth that the majority of folks who are diagnosed with COXI have only lived here a short time, that they just got here, they were just exposed. Many people do actually get diagnosed years, more than a decade after they've been living here. So that's not really helpful for a clinician to ask how long you've been living in Arizona. I wouldn't discount someone just because they've lived here 25 years. They can still have a new diagnosis of COXI. So now we want to present a little bit of data about COXI and community-acquired pneumonia. This all started in 2006 when Dr. Lisa Valdivia and Dr. Galgiani published a study regarding coccidioidomycosis as a common cause of community-acquired pneumonia. It was a fairly small study where 56 patients were recruited with community-acquired pneumonia from 2 primary care sites and an urgent care clinic in Tucson. 19 of those had positive antibody tests for valley fever, or 29%. And 81% had gotten antibiotics, and 31% got more than 1 course. So this raised the concern that maybe in Tucson and probably Maricopa County, up to a third of patients who we think have community-acquired pneumonia really have valley fever. Now this was a small study, and there were some questions and probably different ways one could have designed it. So a lot of folks set out to validate this study. But at the time, that was all the data that we had, and ADHS, based on that study, recommended that patients with community-acquired pneumonia be tested for COXI, and that was in May of 2006. And that was a big impetus for us to start getting education out to both docs and the public to educate them about COXI presenting as community-acquired pneumonia. And we were able to send out primary brochures to every primary care provider in Arizona. And we distributed another poster targeting EDs, basically reminding ED docs to test their community-acquired pneumonia patients for COXI. This is the brochure that we put together. So one of the studies that sought to validate the Valdivia study was a border infectious disease surveillance study on cocci and pneumonia. And the goal was to evaluate the number of patients presenting with community-acquired pneumonia in Tucson ERs that were tested for valley fever. It was also to determine the unmeasured burden of valley fever among the patients diagnosed with community-acquired pneumonia. And they looked at medical record review of all the patients that presented with community-acquired pneumonia. And unfortunately, only 17% of community-acquired pneumonia patients seen in the ER were actually tested for valley fever, which made it a little difficult to further evaluate. And that was despite health department recommendations to test the patients for valley fever. In the end, about 6% of these patients were positive, but we think this is an underestimate because the test that was used was immunodiffusion, which we know misses a lot of folks early in the presentation. And a lot of people who come to the ER with their disease are earlier in the course of disease. So now we had an estimate of 6% that we believe to be an underestimate, and then the Valdivia estimate of 29% based on a small study. Finally, Drs. Kim and Blair did a study, a prospective study of 59 community-acquired pneumonia patients, and they actually were able to do paired serology on all these patients, and they found that 59% of them actually got the paired serological test, and 6 of those, or 17%, actually had cocci pneumonia and did not have a bacterial cause. This is the study that identified that the only way to differentiate cocci pneumonia from community-acquired pneumonia caused by bacteria is the presence of a rash and the laboratory testing. So when you're only looking at the clinical portion, they present exactly the same unless there's a rash. So it's very important to actually order that serology so that you can differentiate the two. This particular study also looked at the medical history, the history of, I think, a recent history, time spent in the endemic area, and the chest x-ray. And none of those things were helpful in differentiating cocci pneumonia from community-acquired pneumonia, again, underlining the importance of ordering that serology. So 3 studies, 3 answers, depending on the way you define community-acquired pneumonia, how you diagnose the disease, and how much follow-up is required. You got an estimate of 6%, 17%, and 29% of community-acquired pneumonia patients actually have cocci in endemic areas of Arizona. I tend to go with the middle, which is about 17%, but that's almost 1 in 5 patients who are thought to have community-acquired pneumonia actually have cocci, and to me, that's a huge impetus to test those patients for cocci. There was a knowledge, attitudes, and practices healthcare provider survey done because there was some evidence that maybe healthcare providers, that we really didn't know what they knew about cocci. There were no data available on this, and we had seen through our enhanced surveillance that there were delays in diagnosing the disease, both due to patient behavior and due to healthcare provider practices. So the objective of this study was to assess healthcare providers' knowledge, attitudes, and practices regarding the diagnosis and the treatment of cocci in Arizona. This was a cross-sectional survey. It was self-administered. There were 2 mailings in October and December of 2007. And there were almost 8,000 recipients. About 5,500 were licensed primary care physicians, and just over 2,000 were licensed nurse practitioners. The questionnaire asked about demographics, clinical degree, field of specialty, and practice history. Some questions about knowledge, including burden of disease, vaccine availability, and disease reporting. Attitudes, general confidence in the ability to diagnose and treat the disease. Your practices, whether you counseled patients after they were diagnosed, how you diagnosed cocci, how you treated them, and when and why you asked for a referral. And lastly, we put together 9 treatment case scenarios based on the current IDSA guidelines for treating cocci. 5 of these we felt were relatively straightforward, but I think the reason why this room is full is because nothing about diagnosing and treating cocci is all that straightforward. So we picked 5 that we felt were straightforward and did an analysis on how many of those were answered correctly. So as you can see, of the 9,000 folks that received the survey, we ended up getting 755 respondents in the first round, over 1,000 in the second round, and overall about 1,800 providers answered the survey, representing 24% of the total respondents. It's a pretty low response rate, but it's a fairly high end. And for medical providers, it's not the worst. So looking at a summary of the results, we learned that about 1/3 of providers were not aware that cocci is a reportable disease in Arizona. About 1/3 of providers were not sure if a cocci vaccine was available. And only 2/3 were confident in their ability to diagnose cocci, and about half were confident in their ability to treat. And that was one of the huge impeti to continue providing this primary care continuing medical education course annually in Arizona so that we could inspire confidence in physicians both in their diagnosis and treatment of the disease. This was the first knowledge, attitudes, and practices study conducted in the U.S. Looking at the knowledge portion, 37% answered 2 out of 2 knowledge questions correctly. And looking at those 5 treatment scenarios, 42% answered greater than or equal to 70% of those treatment questions correctly based on current guidelines. Unfortunately, less than 20% provide valley fever educational materials to patients, which is why we developed some materials and we like to provide them for free. And if you want any more, please let us know. We'll get you what you need. And then lastly, providers who received valley fever CME in the last 12 months were twice as likely to test their community-acquired pneumonia patients for cocci and twice as likely to score greater than 70% on that knowledge, on the knowledge questions. And that told us that CME was actually useful. Of course, the limitations were a low response rate, that it was self-response and probably biased, and that certain number of professionals weren't included, but we did feel like it was fairly representative data. This is a picture of the brochure that's in the back. We've been reprinting them because folks seem to like to share them with their patients. We also were able to do a video, Valley Fever, the Impact on Arizonans. If you want a copy of that, let me know and I'll see what I can do. And this is a picture of the poster we have that you can put up in your offices. It says cough, fever, exhausted, ask your doctor to test you for valley fever. And that's just to sort of remind patients that if what you think you have is a cold or pneumonia, then you should always consider cocci, and it's okay to prompt your clinician to think about it. So in summary, reported cases of valley fever have been increasing in Arizona for the last decade, especially in older persons. There are significant delays in diagnosing cocci, both due to healthcare provider and patient practices. And cocci does have a tremendous impact on Arizonans, on the healthcare system, on the economy, and on quality of life. So it's worth learning more about this disease, and it's worth diagnosing it accurately and early. So please remember that cocci is a reportable disease in Arizona. Think of cocci early and often in patients with prolonged respiratory symptoms, that's greater than 2 weeks, and test your patients with community-acquired pneumonia for cocci. And this is actually the public health website for valley fever. You can get that annual report with the enhanced surveillance data. And if you go to this www.valleyfeverarizona.org, it actually has a link to the Valley Fever Center for Excellence. So we work very closely with the Center for Excellence, and we encourage you to check out both websites. I'd like to acknowledge the following people for all of their help with the presentation.